This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
It's a fact women can't escape. 1 in 8 in the United States will be diagnosed with breast cancer in their lifetime.
It's a treatable disease. It really is a treatable disease.
And one key lies in early detection.
This is a great technology.
See how new 3D technology is improving on the traditional mammogram.
There's about 24% increase in finding an early breast cancer with 3D.
Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
Good evening. I'm your host, Teresa Lukens. Breast cancer is the most common type of cancer diagnosed in women in the U.S., excluding skin cancers. With 3.5 million breast cancer survivors in the U.S., chances are you know someone who has been touched by this disease. In the next hour, we're going to take your calls and hear from doctors who diagnose and treat breast cancer. Joining me for that discussion are Dr. Stephanie Moline. She specializes in surgical oncology at Cancer Care Northwest. Dr. Amy Henkel works at Inland Imaging, where she specializes in breast imaging. Dr. Corliss Newman works at MultiCare Rockwood Cancer and Blood Specialty Center. Her specialties include hematology and oncology. And Dr. Zachary Guss specializes in radiation oncology at Cancer Care Northwest. And we also welcome your phone calls and your questions as you join the discussion this evening. And you can be sure and watch us on Facebook if you're not able to watch us right here on KSPS. And I want to thank all of you for being here tonight for this important discussion on breast cancer. And Dr. Newman, let's begin by defining what breast cancer is.
Well, breast cancer is simply cancer that starts in the breast. And we think it's from cancer or from normal cells that have become cancerous. They grow in the breast, and they can sometimes spread to other places. But it's important to know that the cells are thought to have originated in the breast.
Mm-hmm. And there are different types of breast cancer, but again, it's basically those cancer cells in the breast.
Correct. They're different. There can be different. The cells can have different markers that are expressed or look different under the microscope. So there are different kinds of breast cancer, but they all originate from breast tissue.
Mm-hmm. And we know from research that mammograms are the best way to detect most breast cancers. Is that correct?
Absolutely, yeah. Mammograms are the only test that we have that's been shown to decrease mortality or the number of deaths from breast cancer. Since mammograms were introduced in the late 1980s, the mortality rate from breast cancer or the number of women who have actually died from breast cancer has decreased 30 to 40%. So mammograms are absolutely the best way we have for looking for breast cancers and finding them early when the treatments are most effective.
Mm-hmm. And let's go over the guidelines for mammograms, because they have changed a little bit in the last few years.
Yeah, in some ways the guidelines have changed a little bit, or different groups have come out with some different guidelines that are definitely confounding and really confusing for patients and for the clinicians that take care of them. And what we used to say, and what honestly we still say, the most effective screening regimen is getting a mammogram annually, once a year, starting at age 40, and getting them for as long as you would get treatment for breast cancer. But several years ago, a government group called the United States Preventive Services Task Force came out with some guidelines that differed from that. They suggested that maybe you could start later, maybe you could do it every other year. But those guidelines weren't based on the best science, and the task force that came out with those guidelines didn't actually include anyone who who cared for patients with breast cancer. So it didn't really have any breast cancer experts on those guidelines. And so then a couple of years ago, the American Cancer Society came out with some guidelines. They actually did a really nice review of kind of all the best studies that we have on breast cancer right now. And they published a really nice review of those studies, but then they sort of muddied the waters a little bit by saying, well, we'll save the most lives if we screen annually starting at 40, but maybe you could start at age 45. And maybe at some point you could switch to every other year. And so it just became very confusing because women didn't know what they should be doing, and even talking with their doctors didn't always help them because the doctors didn't know either. So what the science tells us, what women should be doing is getting a mammogram once a year, starting at age 40. That's how we're going to detect the most breast cancers. That's how we're going to save the most lives and decrease the actual number of women who die from breast cancer.
So starting at age 40.
Yeah, absolutely.
Best recommendation. Dr. Moline, what will patients notice? Any other signs or symptoms besides having a mammogram?
Well, we think of it as being passingly familiar with normal. If you know what normal is as part of a health general exam, what's your normal exercise, what's your normal skin, moles, look for differences in the breast tissue. And that a woman is the one most likely to notice what those differences are. So if you're used to lumpy bumpy, you would notice something different sooner than someone who's doing an exam on you might notice. And to do self-exam to the extent of being familiar with normal. Monthly is picked because it's really easy to remember. In a premenopausal woman, it helps to know what the hormonal things are going on to catch the breast when it's the least lumpy and bumpy. And postmenopausal is just a good, convenient way to remember. If you check yourself every day, it might be kind of like watching grass grow. You might not be able to tell a difference. But if you check yourself once a month, you're close enough time to be familiar. We remember things monthly, like bills and things that happen every month. Kind of works pretty good. And annual mammography, one of the things we've seen as women have been more confused by some of the conflicting guidelines is that 2 years flies by really fast, and then all of a sudden it's 4 years, and that the women who meant to do it every other year, somehow it got lost in the paperwork, it got lost in the time frame, and it just makes it harder to remember to do it. Just a functional thing when they meant to do it every 2 years.
We see that frequently. Women who think they were just here a year ago, and it was really 3 years ago. So, and then when you stretch that out even more, it can be a long time between mammograms.
On those I'm sorry.
I was going to say, one of the things that I think is very important to stress is that mammograms pick up breast cancers when they're tiny, usually before you can feel them. And so we do think breast exam is very important, but it is actually more important, I think, to get your mammogram every year, because you are going to do so much better and have such a higher chance of cure if your breast cancer is caught early, and you're more likely to catch it early with that mammogram. Usually by the time you feel a breast cancer, not always, but usually by the time you feel a breast cancer, it's pretty big. So mammogram is key for that.
And what's going to be spotted on an image?
Well,
what are you looking for?
Right, so mammograms are black and white. They're made up of breast tissue, the breast tissue stuff, which is mostly white, and fat, which is black. And cancers are also white. So what we're looking for is, it's often very subtle, but we're looking for masses, or sometimes things called calcifications, which are little like white dots. And we're looking for changes year to year too, which is another reason that it's really important that women continue to come in and get their mammogram every year, because we're looking for really small, subtle changes, and sometimes it can be a really subtle change.
Okay. That brings us to a very good point. We want to talk more about mammograms, and they've been around for decades, and they're recognized as one of the best ways to detect breast cancer, as you've already heard. New now, though, is some technology making them even better, helping doctors see cancer that they may have missed in previous exams.
Julie Smith has done this countless times in her work as a mammography technologist.
And I've been with inland imaging for about 21 years. And I've been doing mammography for close to 30.
In that time, she's seen advances in mammograms, but nothing quite like the jump from 2D to 3D.
The 2D would have 4 basic images, and then the 3D actually has upward of 300 images for a screening mammogram.
The information provided by 3D mammography is unquestionably better, not only zeroing in on cancer faster, but reducing false positives and patient callbacks.
So today we're going to go ahead and do a screening mammogram.
For the patient, it looks and feels the same as a 2D mammogram, though it does take a bit longer. And there's a slight increase in the radiation dose, but not much.
So I'm going to have you come up right
Julie says 3D is ideal for women with dense breasts, but stresses all women need to be screened regularly.
I often, over the years have had women come in and say, well, gosh, I only come in every, 5 or 6 years because I have no breast cancer in my family, so I'm not concerned. And unfortunately, about 75% of the women who have breast cancer have no first-degree relatives with breast cancer.
In the end, it's about early detection, and that's what 3D does best.
When we're screening and we want to do early detection, you want to use every tool that you have in order to accomplish that, and the 3D mammography really is a wonderful tool for that.
And that's the key when it comes to breast cancer.
It's a treatable disease. It really is a treatable disease.
Dr. Henkel, is this a game changer?
3D mammography has definitely been a real improvement in the way we do things. Like I was saying before, a lot of cancers can be really subtle, and cancers, like I said, are white on a mammogram, as is most of the breast tissue. So what the 3D or the tomosynthesis kind of allows us to do is, instead of looking at a single two-dimensional image, we take that series of images, create a three-dimensional stack of images, and then we can slice through it. So sometimes we can find little things that are hiding or would have been masked by some of that dense breast tissue. So it definitely helps in that way. Some studies have shown that I heard in the clip that it decreases the false positive rate. And what the false positive refers to is that when you get a screening mammogram, about 10% of all women who get a screening mammogram are going to be asked to come back for some additional views or an ultrasound. There's something on the mammogram, we want to look at it a little more closely. And most of those 10% that get called back, most of those women are going to be told that there's something benign in their breast. Maybe it was a benign cyst, maybe it was a benign mass that we saw. Maybe it was just simply some overlapping breast tissue. And those women are what people refer to as false positives. There was something on their screening mammogram, but it's not breast cancer. And so what the tomosynthesis allows us to do is some of those things that were just overlapping normal structures, we can actually tell that initially, and we don't need to call those women back. And it is very scary for women when they get called after a screening mammogram and told, oh, you need to come back and we need to look at something again here. A lot of women, they immediately think, oh, I have breast cancer, and most of them don't. And so, having a way to reduce calling back some of those women is definitely very helpful.
Do you have to request the 3D mammography, or is it presented to you when you schedule your mammogram?
Yeah, at Inland Imaging, we offer it to everyone, but we offer women the choice of having the 3D or the conventional 2D, primarily because not all insurance providers currently cover 3D mammography. So we offer women the choice of the 2D. Not very many women actually choose 2D mammography, though. Mm-hmm.
I have a question actually for you. Yes. So can you talk about the radiation exposure difference? Because there is a difference. Is there a difference with 3D versus 2D?
It's a minuscule difference. It's essentially the same. So for a traditional two-dimensional mammogram, 4 views is about 0.4 millisieverts of radiation. And for the 4 views with tomosynthesis and what we call a synthesized 2D, which means we take our sweep of images across the breast and we generate our stack of images, and then the computer also kind of generates an image that looks like that conventional 2D image. And that's currently what we're doing. That is essentially the same radiation as what some places do sometimes is they do the tomo sweep, and then they also take a conventional 2D image as well. So that would be about twice the radiation. It's still, either way, it's still a super, super teeny tiny dose of radiation. I like to tell women it's about the equivalent, a mammogram, a screening mammogram, is about the equivalent of like a few weeks worth of background radiation. So it's like radiation that we're all exposed to just coming out of the ground. Or I know some radiologists who like to say the radiation from a mammogram is about the equivalent of a flight to Paris. So it's a really teeny tiny dose that we're talking about.
Dr. Guss, once we'll get you in on the discussion here, once the diagnosis is made or those images come to you, then what? You determine the stage of the cancer and treatment options? Absolutely.
So we use a combination of both diagnostic imaging and the clinical exam to help assign a stage for a patient. And so we have a range from 1 being, in general, the earliest stages disease to stage 4, or a metastatic disease where the cancer has left the breast in the regional area and has spread to other parts of the body. Historically, we've focused on what we call anatomic staging, meaning how big is the tumor in the breast, how many or how big are the lymph nodes in, say, the axilla, or essentially the armpit and the other regional areas, and then are there tumors outside of that area? Now, in the last year or two, we've entered an exciting time where, in addition to incorporating those more traditional features, we're actually looking at things that the pathologist can detect under the microscope to help refine our prognosis, so that we realize that not all tumors of the same size have the same prognosis, and therefore, with this better understanding, now we can even better pair the right treatments for the right patient.
So that could be radiation, it could be surgical. There's a team approach here, yes?
Definitely a team approach. It's almost always surgical, because in the breast, arising within the breast, is basically where the stem cells are. So that's where the cells that started, this proliferation process started for so many different reasons. And so you want to take out the stem cells. So surgery is almost always a part of taking out the originating site. And then most of our other treatments have to do with what we can do about the cells that may or may not have spread. Radiation is to help treat cells we can't see, but we know they're there, kind of like little satellites. And medicine, whether it's chemotherapy or endocrine or hormonal therapy, we call it endocrine, but kind of what we mean is anti-hormone therapy, can be used against breast cancer, is to treat cells not just that might be lingering in the breast, but also cells, more importantly, that might have left.
Okay, we have our first phone call this evening from Marie here in Spokane. Marie, thank you for waiting.
Thank you. I really appreciate listening to this dialogue. A question I have is, I was diagnosed with breast cancer in 2000 in the right breast and treated, and then 3 years treated with radiation, and 3 years later in the left breast there was lobular carcinoma discovered. So since then I've had, in addition to a mammogram every 6 months, either a mammogram and then an MRI of that breast, and so we're 16, 15 years out, and I was told at the time that that's important because lobular carcinoma gives you a 10 times increase in the normal population of having that change 20 to 25 years later. What are the thoughts? Is that a good idea? I feel comfortable. It makes me feel more secure. Is that still appropriate to be doing that?
Is your question, is it appropriate to be getting a screening MRI in addition to your mammogram?
Yes, every 6 months. I've done that ever since.
Yep.
Because, yes.
Yes. So yeah, absolutely. So MRI is another tool that we have for looking for breast cancer. It's very sensitive, meaning MRI can help us see things that we can't see on a mammogram. And lobular cancer is a particular type of breast cancer that can be very insidious and very difficult to see on mammograms. And we kind of reserve MRI for kind of, there are three kind of times to get a breast MRI. One is when you're initially diagnosed with breast cancer, for staging, to kind of get a good look and see if there's anything else in there. Another instance is for like a problem solving, when a mammogram or ultrasound isn't quite answering a question for us. And then the third instance is what Marie's talking about here, which is screening. And we use screening breast MRI for women who are high risk for breast cancer. And having had 2 breast cancers, Marie is definitely in that high risk category. And so absolutely for women that are high risk for breast cancer, we do recommend getting an annual MRI in addition to a mammogram. And a lot of women choose to do it the way Marie does, which is alternated every 6 months with their mammogram, so that their breasts are being looked at in one way or another twice a year instead of once a year.
Okay, very good. Dr. Moline, talk about the different types of surgeries. There's lumpectomies, mastectomies. Where do you begin?
Well, you start with good imaging and you start with good exam to try and figure out what you need to take out. Where is that home base for the tumor that we want to take out? And so with the best imaging that we can get, we kind of say there's the center, about how big is it, how much of a defect are we going to make taking this tissue out, and what can we do to try and achieve the best function that we can. If we're going to do a lumpectomy, that basically just means we're taking out a lump, but it might not be a lump that you can feel. It's just a little semantics that we're saying we're taking out a lump of tissue with the center being whatever's bad, trying to get a rim of normal tissue around it to get negative margins. So the idea is to say, how did we find it? What looks different about it? And can we take it out and not make too big of a defect in the breast? And what are the other risk factors? If a woman has high risk factors to have another breast cancer, or we take it out and we find it's bigger than we thought and we can't predict it, then decisions for a mastectomy. And there are lots and lots of reasons for why some women with the same exact looking cancer may choose one option or the other.
And you're most likely having a lot of those conversations.
So actually, really the breast surgeon has most of the conversations with the patient about local therapy, how best to treat. I think it's always a decision that's made best between a patient and her surgeon about, is she going to do a lumpectomy and keep part of her breast? What will the cosmetic outcome be from that? Or would she prefer to choose a mastectomy? And some women are even choosing to have both breasts removed and have plastic surgery reconstruction. And that is actually a decision. I'll answer my patients' questions when they have them, but I really think it's a decision made between them and their surgeon, because that's a very technical decision based on imaging and patient preference and what they're, and if they do have a lumpectomy, sometimes they have to go back and have more surgery if there is more tumor than what's expected. And again, the decision about what's going to happen is going to be based on each individual patient and what her cosmetic outcome will be with additional surgery. So it's very technical. That's actually something I don't get a lot involved with. I'm more the chemo and hormone type therapy.
Well, I was going to say, is that when then the chemo or the radiation decision is made as well?
So actually, I think it's the radiation, I'll let you speak to. The chemotherapy decision can be either before or after surgery, and it depends on a number of things. So one of the things is the size of the tumor. If the tumor is large and if a woman is hoping to keep her breast, sometimes we need to do things to shrink the tumor before she has surgery. Another decision point that's actually a huge part of our decision for whether or not to use chemotherapy is a 21 gene assay called the Oncotype score, and that's based on the biopsy. We actually look at the genetic profile, and that 21 gene profile helps us predict which tumors are going to be more aggressive and which are going to be less aggressive, almost regardless of lymph node status, whether their lymph nodes are involved or not. So for a lot of women who actually, with their biopsy, if we know that they have an aggressive tumor and they're going to require chemotherapy, Sometimes those women are actually still deciding what surgery they want, whether they want plastic surgery with reconstruction. Sometimes they're going between different surgeons, like their breast surgeon and their plastic surgeon, to work out these decisions. And sometimes we'll actually do chemotherapy while they're doing that and kind of get it done so that they can be ahead of the game by the time they go to surgery. So those are the types of discussions I have, and I'll work very closely with our surgeons and our radiation doctors to coordinate that.
Walk us through that radiation process if it's decided that's needed.
Sure, absolutely. And so radiation therapy can be a part of a care paradigm for a patient at any stage, you know, from 1 to 4. In the early stage patients, it typically is after a lumpectomy, and several weeks after the surgery, we tend to have a planning session, which is essentially a special type of CT scan. And then we take a three-dimensional picture of a patient, and we design radiation beams to come in such a way that we maximize delivering radiation to the breast tissue while trying to protect really important parts of the body that don't need the radiation, like, for example, the heart. After working with a team of people behind the scenes, physicists, dosimetrists, the patient comes back and then typically receives somewhere between 3 and 6 weeks of radiation therapy, depending on the dose and the stage and the various risk factors. More advanced patients where the breast cancer has spread to other parts of the body can receive radiation therapy for specific problems. I tend to rely on systemic therapy to fight the breast cancer more broadly, but for specific issues such as pain or problematic lesions in the bones or in the brain, radiation therapy can also be an absolutely essential part, typically delivered in shorter courses to help relieve symptoms or prevent problems from arising in the future.
What are some of the questions you get from patients when you tell them that they're going to need radiation therapy? Are they frightened by that?
Sure. Well, many people don't have a lot of exposure to radiation oncology, which is the therapeutic delivery of radiation, whereas most people at some point in their life have had diagnostic radiology at some point, whether it's a chest x-ray or mammography. So much of our discussion regarding the technical aspects is really just what is the radiation that we're delivering, how do we do it, and what is the experience. Certainly one of the questions we're asked a lot is, will I be radioactive? For breast radiation, the most common ways we do it, the answer is no, you will not be radioactive. No superpowers, unfortunately. But essentially it tends to be a well-tolerated treatment, and as the early stage breast cancers tend to receive several weeks of therapy, we meet with them routinely and we get to know each other, and it's a wonderful patient-physician relationship that we can develop.
Side effects to radiation after they go home?
Absolutely. So radiation therapy for early stage breast cancer is delivered in the outpatient setting. So for those several weeks, it's about a 20-minute session each day. The side effects early on are minimal, but what we do, the reason why it takes so long, is we give a little dose each day. And we do that because that's tough on the tumor, but easier on the healthy tissues that we're trying to protect. And so early on, there aren't many symptoms, but then many women will develop skin irritation, possibly some fatigue. That's why it's absolutely essential that we meet with them. When we have to treat more aggressively, sometimes shortness of breath, or some pain with swallowing can be an issue as well, depending on how aggressively we have to treat the lymph node basins. But for these relatively short courses of radiation therapy, it tends to be well tolerated, maybe with some swelling of the breast and pain. There are also some other avenues where people are exploring different types of radiation therapy, whether it's in the operating room or trying to shorten the course as much as possible. We're always trying to make sure that we're pairing the right amount of radiation to the right patient, because we want to give it where it's needed and withhold it when it's not.
And with chemotherapy, I think one of the things most women worry about anyway with chemotherapy is losing their hair. Is that still the case? Can that happen?
Yes, with most of the chemo drugs that we use, you do lose your hair with breast cancer. There are some regimens that you won't, or at least you're very unlikely to, but the best regimens, unfortunately, you typically do. So we talk about options, but I try to encourage my patients to do the best one and not worry too much about hair. Most of the time, almost always, the hair grows back.
What other drug options are available?
Well, so there's really kind of two main categories for systemic treatment of breast cancer. And for early stage breast cancer, the systemic treatment, the goal is to reduce the risk of systemic recurrence, because we know that cancers, although we're likely to cure them, there are some that can come back. And with systemic therapy, we can reduce that risk. Mm-hmm. So, and then with patients with advanced cancer where it's already spread, systemic therapies can help keep it at bay. So there's two types in broad categories. There's chemotherapy, and then there's endocrine therapy. And I guess we should probably say there's a third type, which is immunotherapy too, because there is that option with breast cancer, particularly for HER2-positive breast cancer. So chemotherapy is, of course, sort of glorified. It's basically poison. We're poisoning cancer cells, and it's given intravenously for the most part. There are some that's in pill form. Hormone blocking therapy, which is exactly what Dr. Moline said. It's hormone therapy where we're basically trying to lower estrogen levels or block estrogen from stimulating breast cancer cells, is in pill form most of the time. There are some shots that we sometimes use as well. And then immunotherapy, particularly the antibodies that target HER2, which is a marker on some breast cancer cells, not all, is typically given IV. I think there's a pill that's come out as well lately too. So we have lots of new things.
I was going to
it's
say,
always
lots
changing.
of options.
I have to keep up myself. It's hard sometimes.
Yeah, so many things to consider then, and it can probably be very overwhelming for patients to try to come to this.
It is, yeah.
And so generally I write everything down, because nobody can really, even if you just finished your biochemistry class, you really have to kind of know and see this and write it down and look at it and pull these pieces together. If we had a chart here to share with you on what we need to do, take the whole table, and there'd be lots of columns, and we'd probably need our reading glasses to see which different one to go through. So it's good to have a good team approach to it. And just thinking of the estrogen made me remember that we also get the question that it's estrogen fed, and breast cancer cells aren't fed by estrogen. They're not caused by estrogen, because you pretty much have estrogen in the woman from puberty to natural menopause for 35, 40 years on average. And if breast cancer was caused by estrogen by itself, pretty much everybody should have breast cancer. And you should have lots of them, because the whole breast of both sides is stimulated by estrogen. It's more of a factor that when we're talking about estrogen receptors, that the normal cells have receptors, and about 80% of the time when cells go bad, they keep that receptor. And it's actually a good thing, because that means it's closer to normal. It also means that we can attack it. We can use our anti-estrogen medicine, and there are a great number of them. You don't have to go too far on commercial TV to get a commercial for a couple of them coming out to say ways to attack the breast cancer, almost like a Trojan horse, to attack it. And actually breast cancer is the first cancer where there was directed therapy. Instead of giving toxic chemo that killed a bunch of innocent cells, you directed your anti-estrogen therapy to your breast cells. So yes, you could turn off the normal breast cells, but that was probably a good thing. They couldn't go bad if they weren't doing anything. And in fact, some of our estrogen therapy would decrease, or anti-estrogen therapy would decrease the chances of second breast cancers, such as what Marie was talking about. Not obliterate them, but decrease them. So we use directed therapy to try and attack the bad cells and leave the good cells alone. And that's just one technique our anti-estrogen medicine might do.
What about genetic testing? There's been a lot of discussion about that in the last few years, about especially for breast cancers that run in families. What do we know about it? How accurate is it? Do any of you recommend it?
I think it's a daily event. So we have a discussion, and we don't just say, hey, do you have breast cancer in your family? We draw out a family tree, because if your parents died early or your dad had 6 brothers, we don't have enough females in the family to know what their breast history would be. There are just not enough females in the family to show it. We look for certain factors, and the big broad categories would be a breast cancer diagnosed at 45 or younger. Any age is too young, but that's too young to clue us in that something might be predisposing this breast to do something so early. Triple negative breast cancer, where it has forgotten its estrogen receptor and it didn't pick up that HER2 new. So it's estrogen, progesterone, HER2 new negative, so-called triple negatives, is more associated with genetics. And that would prompt us to do genetic testing. or 3 family members, so mom, sister, cousin, mom, sister, aunt, mom, sister, grandma, something like that, would cause us to think that's too much in a family, and that would be an indication for genetic testing.
Okay. We have Jean from Calgary. Jean, thank you for waiting.
Yes, hello.
Hi.
Hello. Can I talk? Ask me a question? Hello?
Yes, you can. Go ahead.
Yeah, what I'd like to know is I have a friend, she's 72 years old, a young 72, and she just found she got breast cancer, and she's had her operation, and lymph node is good, but they removed the cancer. But now, as you were talking earlier about these specks around the area, the calcification, and I just wondered if, how people can psychologically handle this, because she's having a hard time, and she's kind of stubborn, refuses to go to group efforts or to some therapy or anything. But she goes to the doctor, of course.
Okay. Dr. Newman?
Well, diagnosis, any health problem brings stress. And I think cancer brings a great deal of stress because for so many years, cancer has been associated with death. But we cure a lot of breast cancer. Actually, most breast cancer is cured. And I try to really reinforce that with patients, even the ones that we are going to recommend chemotherapy for early stage breast cancer. We talk about treatments and we talk about side effects, but this is a short time that you're on treatment for a potentially huge impact on your life. So I would encourage your friend to not be afraid. She probably has a curable breast cancer, and to go talk to her doctor about the best treatment for her, realizing that we really individualize our care. We're not sitting here telling you exactly what to do for each patient because every single patient is a little different. And her doctors will sit down with her. Her surgeon will talk to her about the recommendations from her surgery standpoint. Her medical oncologist will sit down and talk with her about the different choices she has, and we'll give her the choices that for her to choose. It's not, we aren't going to force anybody to do treatment that doesn't want to do it, but we'll, make a good case for what we recommend and then tell you what your options are. And radiation, it's not that hard. It's a time in your life, but other than some fatigue and maybe some skin irritation, most patients do really well and find it not hard. And we're all really nice too, Most of our patients, we love our patients and most of them love us. So I would encourage tell your friend not to be scared. Tell her you'll go with her and be another set of ears for her and tell her not to be afraid.
Yeah, I think that's always important, especially with an important diagnosis like a cancer, because I think your brain gets a little foggy, you're immediately fearful. So if somebody else is in the room with you to help you answer those questions, or just retain the information that the doctor's telling you, that can be really helpful. Our overall health, what can we do to sort of help stave off breast cancer? I know some people are predisposed, but how can we help our chances of not getting a breast cancer?
Don't smoke. Don't drink a lot of alcohol. And probably less is more on the alcohol thing. It keeps getting better and better that you shouldn't drink much alcohol for any type of cancer, by the way. And maintain a healthy weight. Those are by far the top 3 things you can do. Stay active, maintain a healthy weight, don't drink too much, and don't smoke, don't use tobacco products. Then there's a few other things that improve your odds of not getting breast cancer. Breastfeeding actually reduces your risks for breast cancer.
Really?
It does. Although, all of us are women and we all have estrogen, and, estrogen doesn't, there is a slight risk of increased risk for breast cancer if you take hormone replacement therapy after menopause. There are some benefits to hormone replacement therapy. This is a question that you really need to weigh carefully with your physician because there are pros and cons to that. But if you have a strong family history of breast cancer and you're worried about breast cancer, you might avoid hormone replacement therapy after menopause because there is some concern with that. And then, I don't really want to advocate pregnancy the younger you are, because that's not really a reason to get pregnant early so you can prevent breast cancer. That's really not a good choice. But we do know that there are some risks. The the earlier you start your periods and the later you go through menopause, it does increase your risk a little bit, probably because it's a longer time of higher estrogen stimulation. Delaying pregnancies until later in life might have a slightly increased risk, but those are small. Those are really, really small, and you can definitely breastfeed, and that will reduce your risk. I don't think you should do family planning based on worries about breast cancer, but don't smoke, don't drink a lot of alcohol, maintain a healthy weight, and be active.
And the good thing with that is many of those lifestyle factors like avoiding tobacco and alcohol, maintaining a healthy weight, will help reduce the risk not only of breast cancer, but many other types of cancers and non-malignant conditions as well. So you're really doing yourself a favor on multiple fronts.
So things that are good for your heart are also good for your breast cancer and other cancer risks. Colon cancer and breast cancer share some of that in terms of the healthy weight maintenance and avoiding high-fat diets. A common misconception is that sugar causes breast cancer or any cancer, and sugar doesn't cause it. But if you have way too much sugar, it turns into fat cells, which the fat cells then have a proliferative effect. And that's what some of the common things here are in breast cancer in terms of proliferation. Do everything you can to avoid proliferating the cells. Make the more times they divide and divide and divide and divide without having a break in that, the more times they might make a DNA oops, and the cell may not be able to recover.
Okay. We have an email that sort of goes to that. If you get cured of one type of breast cancer, are you still susceptible to another type? That's from Carol in Coeur d'Alene.
So if you're female and you have breast cells, that is your biggest risk factor. And so if you've had one type, there are subtypes such as lobular carcinoma in situ that increases the risk that there's a proliferation problem, that your cells may be more susceptible. And that's certainly very much of a subtype discussion, if it is. However, just because one side went really haywire doesn't actually mean that the other breast is suddenly high risk. The rate of developing an opposite breast cancer for, say, a 60-year-old woman who's had one breast cancer, that rate is about 0.5% per year. So if she lives 20 more years times 0.5 is 10%, which is less than the 1 in 8 number. 1 in 8 women who reach the age of 90 will have breast cancer. So statistically, it doesn't really increase your risk or doom you to have another breast cancer. The vast majority of women will have one. And many of the interventions, such as our anti-estrogen medicine, will actually decrease the activity of any other cells and turn the rate of a second breast cancer down, depending on your treatment of the first cancer.
Oh, okay. We have Cliff here in Spokane. Cliff, thanks for waiting.
Yes, one of the doctors mentioned immune therapy briefly, and I'm just wondering how effective that has been and if it's actually curing breast cancer.
Yes. Herceptin has been a game changer in the treatment of HER2-positive breast cancer. So when we talk about immunotherapy, I think it is important to realize that there's a lot of different types of immune therapies for different cancers. In breast cancer, the immune therapy that we're talking about is, for the most part, is immune therapies that target HER2/neu. For women who have HER2/neu positive breast cancer, and that's about 1 in 3, I believe, breast cancers will be HER2 positive. Herceptin therapy with chemotherapy has significantly reduced the death risk in early stage breast cancer, and it also improves survival in women with stage 4 breast cancer. So it is absolutely a game changer.
Well, and it being October being Breast Cancer Awareness Month, a lot of donations are made toward breast cancer research. So there's one of the positive notes coming from some of that research. There are advances being made.
Yes.
Yeah, leaps and bounds. I want to tackle a couple of the headlines recently. And Dr. Moline, you already mentioned commercials. We're inundated with those and different new drug therapies. One of the most recent ones was processed meat linked to breast cancer. What do we know about that, if anything? Is it one of those headlines that's put out there that we all kind of take note of, but there's not a lot behind it?
The problem is you can't make people start at age 1 and eat only a certain thing and never have some spam or whatever they're talking about ever. And you can't stop at 50 eating that and necessarily absolve all that risk. of what it is. It's thought that some of the preservatives that make processed meat have a shelf life longer than fresh meat may have some little piece of promoting some of that proliferation DNA boo-boos that might happen. The trouble is going to be a humongous study of 1 million people to study it and prove one way or the other. So the best idea is to say eat healthy in general, avoid things when you can, and minimize that. Be balanced in many things. The closer you get to the natural vegetable, the closer you get to the natural meat, probably the better off you are in many things.
Okay. Maria with a question from Calgary. Maria, good evening.
Oh, hi, good evening. I just wanted to check or to ask the panel, is it advisable to have a double mastectomy even though there's only the one breast that's affected?
We know, at least in the United States, that the rate of women choosing to do a bilateral mastectomy when there's cancer in only one breast has gone up at least 4-fold in the last decade. And our imaging is way better and our medicines are better. And so a lot of people have questioned, why in the world would women be choosing to do this, going up in their surgery? And a lot of it has to do with what you're starting with. So if you started with a cancer that was easy to see on mammogram, and you can do a lumpectomy and radiation and still achieve a very good result, you might not be inclined to do that. If a woman has very small breasts or very large breasts and always wanted to change things, having a cancer and having a bilateral mastectomy might make sense. So a lot of it has to do not necessarily with the cancer reason, but more with other things that kind of go along with it, to either get out of radiation or to get out of some other treatment, such as follow-up. For some women, it can be excruciatingly terrible to have follow-up, that just going for a mammogram puts them in sweats for a month just thinking about it. And so if you had a cancer that was really hard to see on mammogram and was really hard to detect, and you had some benign biopsies and you just were nervous about it, that might have a mental health benefit from doing a mastectomy. But a mastectomy is no great shakes either. It doesn't leave people looking normal. So a lot of the reason thought for why this would be going on in this country would be availability of good reconstruction choices to restore some sense of normal, and just educating that it's an individual choice and that there shouldn't be a blanket recommendation.
Does the reconstruction process start immediately?
We try to. It certainly is easier to start with the envelope of skin that we have than it is to go flat and stretch it out and come back later. But there's, again, another million factors, plus or minus, in that.
After a mastectomy, what can a woman expect, or a man for that matter, after the surgery, and how their breasts look or feel, or what they can expect?
After a mastectomy without reconstruction, is fairly flat. And generally it's an incision the length of the breast width to take out the extra skin so you don't have a bunch of skin flopping around and hanging out, to go flat. And it's usually a little surprising. Many women think it would look like a boy, but even a male person has something in terms of the fat there in it, so it's flatter than most people would expect.
And speaking of men, we haven't brought that into the discussion yet, but men can get breast cancer. Dr. Guss?
That's true. Approximately 1% of breast cancer cases are male, and in many regards, their workup, treatment, and prognosis are based upon the same factors that we consider for women. Of course, there are certain considerations, for example, cosmetic, which factor into surgical decision making. But yes, we do see male breast cancer, and certainly in larger cancer centers, we see quite a good number of it.
And they're not screened regularly like women are, or it's not recommended for them to be screened. So how would they notice a cancer?
By feeling a lump. And most men are relatively flattish, and so it's a little easier to feel things. A lot of the male cancers start kind of behind the nipple or around the nipple, and so they feel that they notice that there's something there, and then in that case their doctor sends them to us, and we do a mammogram and an ultrasound and work it up that way. But no, male breast cancer is rare enough that we don't recommend that all men start getting mammograms to routinely look for that.
Albert in Edmonton. Hi, Albert.
Hi. I've heard reports say that there's been research on connecting breast cancer with the contraceptive pill.
And you're wondering if that's true?
Well, I believe it is true because I've heard it from doctors that have said this, but you don't hear it on the media.
Well, we actually recommend oral contraceptives, which is a humongous category of drugs, and there's not one dose. And the trouble is, if we want to know from 30 years ago, did your birth control pill cause your breast cancer now, the birth control from 20 and 30 years ago wasn't the same dose. And we've learned a lot that we don't need as much estrogen and progesterone in a pill to achieve their primary goal of suppressing ovulation, and that we actually put BRCA positive women who have a genetic predisposition of breast cancer on birth control to suppress ovulation for ovarian and breast risk. There are probably some proliferative changes that might be promoted, but by and large, the best studies show that it's fairly neutral.
Okay. David in Calgary. Hi, David.
Hi.
You have a question?
Yes, I'm wondering whether women with large breasts are at greater risk for breast cancer.
No, I don't think so.
No,
Yeah.
most of the breast, so the breast cancer arises from the ductal, the milk-carrying tubes, or the lobules, the milk-making cells. So ductal or lobular are all this connected system. So every woman has about the same amount of ductal and lobular components. And the difference in the size of the breast is based on, it's the F word, fat, and fibrous tissue, which is actually fairly genetic. So the A cup lady can breastfeed just as much milk as the double D cup lady. It only has farther to go in a different path, but it's the same production. The same cells are at risk. They're just stretched out differently.
I think the only difference would be that it's not so much breast size that might be a risk, it's really obesity, because obesity does increase your risk for a number of cancers, including breast cancer. But the actual size of the breast itself isn't particularly a concern.
No, it might be more difficult to detect if you have a larger breast size. You can't really feel the back of the breast as easily, but a small-breasted woman might have more fibrous tissue and make it harder to feel. So there's pluses and minuses either way, but it's not an absolute indication. Just because you were well endowed and thin, you could not have any more likeliness of breast cancer than someone who's just a small breast.
Mm-hmm. There's been a lot of discussion about a vaccine for breast cancer. Explain what the research is there. Is anyone familiar with the vaccine?
I'm not really.
Not exactly.
Yeah.
The problem with a vaccine like the flu, you need to have something that bothers your immune system. And HER2/neu is a factor that itself isn't an immune problem. Your immune system has no idea that you have breast cancer. And so for the immune system to get involved in any sort of thing in the body, it has to recognize it as not you. There's your cells that are you and you're not you. Like germs. Germs are not you, so you make antibodies. So to do an immune thing or a vaccine, you have to get something that is not you. But breast cancer cells, by and large, don't do anything that your immune system could recognize, so it's really hard to make a vaccine. There are some tumor vaccines, so you could take a woman's tumor and try and squish something out of it that's different, so you could target it just like the HER2/neu. There are a number of cancers where this is very successful, and ovarian cancer has a big immune project and trial going on, and melanoma has long been treated, well, at least over 20 years that I know of, with immune therapies where you can direct the immune system by giving someone an antibody or making an antibody so it'll attack the bad cells and leave the good cells alone.
On a related subject, there's an HPV or human papilloma virus vaccine, which is often called an anti-cancer vaccine, which is very good in terms of preventing the viral infections that cause cervical cancers and many other types of cancers. But as breast cancer isn't caused by an infectious agent, we don't have a similar type of vaccine for breast cancer in particular. But it is an exciting time for the HPV vaccine.
So maybe when they're talking about vaccine, it's not in the traditional sense.
They must
then.
be using a different term because there's not. I've not seen anything. I'm sure there's something. I'm sure somewhere somebody is doing some type of a vaccine
It's again
trial,
one of those headlines
but
that
I don't
popped
think
out
it's,
at me.
It would be very bench research oriented, not ready for prime time certainly.
And it would probably still be, because there's so many different subtypes of breast cancer, it would be directed at an individual cancer for one person, not something that crosses over all boundaries of breast.
Dr. Henkel, how can a woman improve their mammogram? What can we do ahead of time? I know you're not supposed to wear deodorant or perfumes, but what can we do as we head in for that imaging to make sure we're getting a clear image?
I mean, there's really nothing you can do except for try to stay relaxed and let the technologist help you. The technologists are excellent. They know what they need to do to get the image, and I think the biggest hurdle is that patients are nervous and kind of fighting it a little bit, and especially the first time it's an unusual experience, and so just kind of just being prepared to be relaxed and to trust that the technologist knows what they're doing and has your best interests at heart. The deodorant thing is sometimes deodorant or lotions or powders on the skin can show up on the picture. They look like little white specks and they fake us out into thinking that there's something in the breast there, but if you do wear it, it's not that big of a deal. We give you a little towel to wash it off and take the picture then.
Okay, we are down to about a minute, but I want to get some final thoughts from each of you. Dr. Henkel, leave us with a final thought on breast cancer.
My final thought is that I just want women to know that it is so important that they get their screening mammogram every year and start at age 40.
Okay, and Dr. Newman?
If you have breast cancer, you are most likely going to be cured.
Okay, Dr. Guss.
Your breast cancer care will often include many different providers, and it's really important that you feel comfortable and and engage with the team. And if you have any questions, please feel free to ask many of them, because we always want to make sure that you understand what you're going to be going through and help you through the process.
Mm-hmm.
Amen.
Well said, very well said. Well, thank you. That's going to do it for this edition of Health Matters. And our thanks to everyone who called in or emailed questions to us. We appreciate it. And a big thank you to our panel for being here and sharing their expertise. Join us on November 15th when our topic will be type 2 diabetes. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.